Hi, my name is Dr. Vasan. I'm a urologist and an andrologist, consequently a uroandrologist practicing dedicated andrology for the last 25 years in Bangalore, Ankur Healthcare. I'm the director and CEO of Ankur Healthcare. We deal with a lot of erectile dysfunction, and consequently we have always been exploring new ideas of diagnosing erectile dysfunction, because presently diagnosis of erectile dysfunction is based on a scoring mechanism and a rigidity scale and some imperfect tools like penile Doppler, which are very subjective. As we all know, in our daily practice, the two most common complaints we encounter are erectile dysfunction and premature ejaculation. We prescribe, we counsel, we adjust doses, but often we are treating visible symptoms than underlying physiology. The real question we should be asking is, are we truly understanding vascular performance of this patient? As we are aware, we are the diabetic and hypertensive capital in the world, especially in India, and consequently metabolic syndrome is very predominant, and we are moving from an era of a predominantly psychogenic erectile dysfunction to arteriogenic or vascular erectile dysfunction. So how do we diagnose vascular erectile dysfunction? So an erection, for us to understand it better, an erection is not just a psychological event. It is also not just hormonal. It is fundamentally a vascular phenomenon, because there are cavernosal arteries which have to dilate and consequently increase the blood flow. So it requires a rapid arterial inflow, efficient nitric oxide mediated vasodilatation, smooth cavernosal muscle relaxation, and importantly, the arterial elasticity should be so good that it can expand and sustain the blood filling. Rigidity becomes inconsistent if any of this does not happen properly, and also maintaining the rigidity becomes very difficult. These are the two common complaints which patients will come to us in the clinic. The erection may initiate but may not sustain. Many patients describe this as almost good but not like before, and that is often most likely a vascular complaint. So we frequently see these patients who have had partial response to PDE5 inhibitors, or responding and then becoming non-responsive. We increase the dose, we switch molecules, we combine therapies. But if underlying issue is arterial stiffness, then we are not addressing the problem, because pharmacology alone may not overcome the structural vascular limitation. Stiffer arteries means the pulse wave velocity decreases or increases depending on the arterial elasticity. So the stiffer arteries means that the pulse wave travels faster, reducing diastolic perfusion, suboptimal microvascular filling of the corpora cavernosa, which contributes to erectile dysfunction. The result is compromised rigidity or compromised hardness of the penis. Without measuring vascular function, we are often managing blindly, which is an unscientific way of management. This is where I want to introduce a technique or a technology which has been there for many years, but we as urologists and andrologists and sexual medicine practitioners have not used it effectively in our practice because we have not understood it better. So what is this instrument? This is an instrument called periscope, which is available and which becomes clinically meaningful in your andrology practice, because we want to empower ourselves with diagnostic modalities which helps us to deliver treatment at a personalized level, and this is an era of personalized management. Periscope provides a non-invasive measurement of pulse wave velocity and arterial stiffness in a simple automated manner, which is very important because it's completely automated. So there is no learning curve and there is no observer variation which can come into picture, and subjective measurements are not there. We obtain objective information about arterial elasticity and vascular age. It is easy to perform and highly reproducible, which makes this machine an idiot-proof technology which you can incorporate in your practice. Now, how does this change the consultation? That is the primary question we all ask. Instead of telling a patient, let us try medicine and see, oh, I'll give you sildenafil, I'll give you tadalafil, I'll give you vardenafil. I can be more scientific by trying to tell him after performing the test that your arterial elasticity is reduced. This is contribution. Arterial elasticity is a principal contributor to your erectile phenomena because it improves arterial blood flow to the cavernosal space and consequently rigidity. And unless we address vascular health, along with medication or whatever methods we want to adopt, just giving symptomatic treatment will not be meaningful and it may not be curative. So the idea of erectile dysfunction management has also moved from symptomatic management like a headache management to something more curative management. Because everybody wants cure. Nobody wants to be taken a pill for the rest of his life. And we all know the phenomena of tachyphylaxis. The same pill may not be effective after a couple of days or a couple of months. So the conversation shifts from trial and error based prescription to physiological based planning. That is what we all want. We want to be scientific in our approach. Patients understand their condition better because of this. They also have answers why I have developed it. Instead of just saying take a pill of Viagra, it's just like giving a prescription for a headache with a Dolo 650, not understanding why I'm getting headache. They become more compliant with their lifestyle because once you understand the problem, you can tell them lifestyle changes they need to introduce. Metabolic control also becomes easy because they can see measurable data. So not every erectile dysfunction patient is the same. We do understand this. There are challenges in our practice where there are multiple problems people present with. Some have comorbidities, some have diabetes, some have hypertension, some have dyslipidemia, some have psychological factors. So what we are trying to do or trying to say through this video is that we can now confirm arteriogenic erectile dysfunction almost 100%. That is what is the technology available about. So some have normal arterial stiffness and are likely to respond excellently to standard pharmacotherapy. So what does Periscope do? One, not only it gives you information about the degree, whether the presence or absence of arterial stiffness. Second, the degree of dysfunction, who has mild arterial stiffness, who has moderate arterial stiffness, who has severe arterial stiffness, who may be an impending candidate for a heart attack or a stroke risk. And consequently, you can categorize your patients as mild, moderate, severe and devise a strategy. A mild patient may just require pharmacotherapy. A moderate patient may require a pharmacotherapy with a shock wave. A severe patient may require a cardiology consult first for an evaluation of his heart. So it becomes very, very important because you are not only predicting erectile dysfunction, you're also prognosticating his risk for a heart attack. So that is very important because we as doctors are empowered to do this. We can predict heart attack and stroke risk, which is very, very crucial, and it probably enlarges your patient pool by getting the patient into confidence that this machine can help you not only diagnose the degree of erectile dysfunction or the degree of vascular erectile dysfunction, it is also a predictor of your heart attack and stroke risk depending on the degree of vascular stiffness you have. So the question is, the treatment becomes more structured. That once you have a proper diagnosis, you can have a structured treatment, be it pharmacotherapy, be it the shock wave, be it the platelet-rich growth factor or PRP as people call about, or be it a cardiology referral. You can explain the patient to better, and your data which you get from this is very valuable because once you have this Periscope, probably you can repeat after your treatment at the end of 3 to 6 months to see how much changes you've introduced, or you can also prognosticate the treatment plan. So Periscope essentially helps us identify all these various patterns early before repeated drug escalation and patient frustration, because that is very important, because patient gets frustrated if he doesn't respond. See, patient comes to you, this is not a disease where there is a problem. He comes to you because there is a dysfunction and he expects utmost satisfaction. And that is what we hope to achieve. Even in premature ejaculation, where we often consider purely neurobiological or psychological or vascular factors can play a supporting role, this is important because we are able to identify one element of premature ejaculation. It may be still neurologically predominant, it may be a glans hypersensitivity, it may be a bulbospongiosis overreactivity, but still we are existing. We all know that premature ejaculation in many cases has a coexisting vascular erectile dysfunction, and that is what we hope to achieve by identifying. So it's a mass screening tool. What I'm trying to tell you is you do not confine it to only an erectile dysfunction patient. You use this for any patient who walks in, because we all know that erectile dysfunction may be a harbinger for a person to develop heart disease in 36 months, which is what is the Francesco Montossi paper is all about way back in 1996 from Italy. So where he predicted almost 36% of men will develop heart attack in 36 months if they have erectile dysfunction. So consequently, this is a huge group in India, especially because we also have metabolic syndrome, and we are the diabetic and hypertensive and dyslipidemic capital of the world. So periscope is a mass screening instrument for erectile dysfunction, to find out whether there's vascular element, premature ejaculation to rule out erectile dysfunction, and also all diabetics and hypertensives who have need for an erection, or even as a screening test just to detect their the vascular status, especially the pulse wave velocity. You can use this. So wherever erection firmness is unpredictable, performance anxiety increases. We all know this. So this is a group of patients where the doctor decides what needs to be done. So it is very imperative that that we understand that there are technologies available to help us move away from empirical way of treating any patient who walks in with erectile dysfunction. A patient who walks in with erectile dysfunction, generally the tendency is you take this tablet, come after 1 month, you don't respond, I will up titrate it. You don't respond, I will add one more dapaoxetine or SSRI. That is not the way to treat erectile dysfunction. The patient loses confidence in your treatment. This is an era of directed therapy, personalized management. So what I would suggest is buy this equipment, put it in your clinic, use it effectively. If you have any questions regarding the usage or how to interpret, there are various people. I'm available to help you. And I'm sure the company would also. I'm not promoting the company, I'm promoting the technological use, which is extremely useful to you. Join this movement of diagnosing erectile dysfunction, and also diagnosing the heart attack and stroke risk, which is imperative on us as clinicians to pre-warn the patient so that he can institute appropriate lifestyle changes. One life saved may mean a lot to the family and also personally to you. So diagnose erectile dysfunction, treat effectively, use technology, and any help, any guidance you require, I'm always available to help you. Thank you very much and have a good day.